and this way the patient can present to psychiatrist also. So these are the classical symptoms. Other symptoms, it can also affect cardiovascular system. It can cause hypertension. It can cause arrhythmias. Main arrhythmias are bradyarrhythmias and atrioventricular block. It can cause vascular calcification and increase risk of MI. And hypercalcemic crisis that I have already told, severe hypercalcemia with neurological or cardiovascular manifestation. So there is wide variety of presentation of hypercalcemia. And why there is etiology is also broad. There is two. Hypercalcemia can be parathyroid dependent and parathyroid independent. So when we for parathyroid dependent and independent, we will see later on. But this is the variety of etiology. Parathyroid dependent causes there is primary hyperparathyroidism or four glands or single adenoma in parathyroid gland, tertiary hyperparathyroidism, lithium therapy, and one rare cause that is familial hypocalciuric hypercalcemia. And parathyroid independent causes that are malignancy, mainly squamous cell carcinoma, solid core organ malignancy like breast, lung, and kidney, and hematological malignancy like lymphoma and leukemia. They can cause hypercalcemia in variety of ways that we will see later on. Then vitamin D dependent, that is vitamin D intoxication and granulomatous disease like sarcoidosis, tuberculosis, vaginal granulomatosis. In this granulomatous disease, in granuloma there is increased 1-alpha hydroxylase activity. So activated vitamin D will increase and it will increase calcium reabsorption from the intestine and it will cause calcium resorption from the bone. So these are the main etiology: parathyroid dependent, malignancy, and vitamin D dependent. Vitamin D intoxication, very important, because overzealous use of vitamin D may occur nowadays. Sometimes patient comes with pain and we can see the prescription of vitamin D, and I have seen the prescription of injectable vitamin D 6 lakhs units. So high dose of vitamin D can cause vitamin D intoxication. There is upper level of limit for vitamin D. Okay, 4,000 international unit is the upper level of intake. Okay, and more than 60,000 units per day, if taken for 15 to 30 days, it can cause vitamin D intoxication. Okay, so we have to be judicious in the use of vitamin D. Then other etiology are causing mild hypercalcemia, that is hypertoxicosis, adrenal insufficiency. Mild adrenal hypercalcemia can see in these cases, but it will resolve by the treatment of condition. Then immobilization, prolonged immobilization can cause mild hypercalcemia. Then these are the rare Jensen disease. Then other drugs, that is vitamin A intoxication. If it is used more than 10 times the upper limit of recommended dose, upper limit of recommended dose is 5,000 units for vitamin A. If it is used in higher doses, it is certain condition it is used in higher doses like acute myeloid leukemia, so it can cause hypercalcemia. So this is the main stepwise approach you have to follow. First, when you come across the case of hypercalcemia in OPD practice, okay, suppose calcium level is 11.2. First, confirm that it is hypercalcemia or not. Because when sample is taken by venous occlusion by binding tourniquet, it can also raise blood calcium level slightly. So blood calcium level falsely elevated by venous occlusion. So we have to repeat the measurement without tourniquet if we find hypercalcemia. Without venous occlusion, we have to repeat measurement. Second, we have to review previous values. If any calcium values is there done previously or not. Third one, as I mentioned, we have to correct calcium level for the albumin by that formula. Or we have to measure ionized calcium. So first we have to confirm the hypercalcemia. It is true hypercalcemia or not in the OPD practice. And when I talk about indoor practice, sometimes patient comes with severe dehydration. And you can find the calcium value of around 11.4, 11.5 in indoor patients. But because of dehydration, albumin level also slightly elevated. So in this 11.2, 11.5 value can be false hypercalcemia. It may not be true hypercalcemia. So in acute setting, you have to see the ionized calcium. Decide the severity of hypercalcemia. Calcium level more than 40, usually not false hypercalcemia. It is usually true hypercalcemia. And we have to consider severe hypercalcemia. We can consider hospitalization for this patient also, because hypercalcemia, this level of hypercalcemia needs to be corrected. Now, next step is some clinical clues that can guide us towards etiology. So, as I said, primary hyperparathyroidism patient present with classical manifestations. Think renal stone, painful bones, abdominal bones. Okay, it can be asymptomatic or chronic, and some cases like some endocrine neoplasia. There can be family history of hypercalcemia or primary hyperparathyroidism also. So these are the clinical clues that suggest that patient can have primary hyperparathyroidism that is causing hypercalcemia. Then some clinical clues: severe hypercalcemia and hypercalcemic crisis. Generally, in primary hyperparathyroidism, mild to moderate hypercalcemia is there. Severe hypercalcemia is very rare in primary hyperparathyroidism unless patient is dehydration or patient have very severe hyperparathyroidism. So when severe hypercalcemia is there, it is more likely to be malignancy. And we have to also review the medications. If patient is using any vitamin D, patient has taken any high dose of vitamin D, vitamin A, patient is a case of bipolar disorder. Is that he is not taking, is it or she taking lithium? Because lithium equals hyperparathyroidism and hypercalcemia. Lithium used for more than 5 years generally is found to cause hypercalcemia. And prevalence is also around 8 to 10% in lithium causing hypercalcemia. Sometimes diagnosis is straightforward. When present with classical manifestation, patient have bone swelling, diagnosis is straightforward. Yes, it's likely to be primary hyperparathyroidism. Sometimes patient present with no malignancy, breast carcinoma present with hypercalcemia, diagnosis is straightforward. It is malignancy-induced hypercalcemia. So differential diagnosis of hypercalcemia is very good. In outpatient settings, it is more likely primary hyperparathyroidism, and inpatient it is malignancy. So what are the first line investigation? Once you prove that now it is hypercalcemia. Okay. So what are the first line investigation? You will repeat calcium, you will do phosphate, alkaline phosphates, IPTH, intact PTH, 25 hydroxy vitamin D, and serum creatine. So this method of investigation can solve many causes. Okay. So suppose intact PTH. If intact PTH will help in differentiating whether it is PTH dependent hypercalcemia or PTH independent hypercalcemia. If intact PTH is normal or elevated, usually what happens, if serum calcium level increase, PTH should be suppressed. Okay, but PTH is normal. Normal range is 10 to 65. If PTH is normal or elevated, it is PTH dependent hypercalcemia. And what we will consider for what value we consider for diagnosing a PTH dependent hypercalcemia, it is 22 picogram per ml. If PTH level is more than 22 picogram per ml in the presence of hypercalcemia, it is PTH dependent hypercalcemia. If PTH value is suppressed, it is less than 22 picogram dependent hypercalcemia. Most common is primary hyperparathyroidism, and its prevalence is not less as we thought. Some think that it is rare disease. Its prevalence is around 0.5%. But because many cases remain undiagnosed, so we cannot find out many cases. But its prevalence is quite high, 0.5% prevalence. Then tertiary hyperparathyroidism that occurs in the chronic renal failure, long-standing chronic renal failure. Then familial hypocalciuric hypercalcemia, it is genetic disorder and it is autosomal dominant disorder. And I will explain about this disorder in one case scenario. Then lithium therapy, as I already told, lithium if used for long term can cause hypercalcemia. Then other are PTH therapy or ectopic PTH secretion that are very rare. So whenever you find PTH dependent hypercalcemia and calcium level is around 11.4, PTH level is 38, we have to differentiate primary hyperparathyroidism from familial hypocalciuric hypercalcemia, for which we have to do 24-hour urinary calcium and creatinine. If the calcium, usually what happens in primary hyperparathyroidism, there is increased calcium excretion. So calcium creatinine ratio is more than 0.02, it is suggestive of primary hyperparathyroidism. And in familial hypocalciuric hypercalcemia, calcium creatinine ratio is less than 0.01. Now what is the familial hypocalciuric hypercalcemia? There is calcium sensing receptor in calcium sensing receptor in thick ascending loop of kidney, through which calcium is reabsorbed. Sometimes this calcium sensing receptor is inactivated. There is inactivating mutation. It cannot sense the calcium. It senses the calcium low, so it will absorb more calcium. So in urine, calcium level is low. In blood, it is high, and it is autosomal dominant disorder. We can find family history, familial hypocalciuric hypercalcemia. We have to differentiate this condition because management is different. That will I come to later on. Then other is PTH independent hypercalcemia. As I already mentioned the core etiology, I will go to the approach of PTH independent hypercalcemia. See, as I mentioned, we have to do some investigation like 25-hydroxy-vitamin D, 125-hydroxy-vitamin D, okay, and phosphorus and alkaline phosphatase. Okay. So, in PTH independent hypercalcemia, there can be malignancy that causes increased PTHRP secretion, that is parathyroid hormone related peptide secretion, or there can be osteolytic metastasis. So there are two ways that malignancy can cause hypercalcemia. But PTHRP usually not available. PTHRP test is not available in India. So we have to see the indirect clue. We have to see 25-hydroxy-vitamin D, 125-hydroxy-vitamin D, that level. If both levels are normal, then it can be malignancy-induced hypercalcemia. And we have to see other levels like phosphorus level, alkaline phosphatase, and then we have to investigate for malignancy, for most common malignancy. We can get clinical clue about malignancy like lighting bone lesion, multiple myeloma, or leukemia. So in this way we can approach which malignancy we are thinking of that is causing hypercalcemia. In 25-hydroxy, vitamin D is more than 100 nanogram, then it is vitamin D intoxication. But if vitamin D level is normal but 125% vitamin D is elevated, then it is granulomatous disease. As I told, sarcoidosis, tuberculosis and Bacillus granulomatosis, there is increased macrophage, increased 1-alpha hydroxylase activity in granuloma, and that can cause higher calcium level. So in this way, we have to approach. Now I want to.
What calcium level should be investigated patient to hypercalcemia?
More than 10.5.
Any patient more than 10.
More than 10.5 we have to investigate.
Hypocalcemia?
Hypocalcemia is less than 8.5.
So any patient less than 9.5 we should go for.
I think less than 9 we can investigate, but we have to correct it with albumin. Corrected calcium we have to see.
Then simultaneously albumin is okay.
Yeah.
Calcium is less than 9. Then we should go for PTH and further one.
Yeah.
But we see vitamin D low in our Indian population.
Yeah, it is 70% of Indian population is vitamin D deficient, but every time it doesn't cause hypocalcemia. So, because this depends on many factors, vitamin D receptor polymorphism, like vitamin D level is low, but 125 vitamin D may normal. So, what body absorbs the calcium from intestine is the one activated vitamin D.
There is vitamin D reference is okay for Indian population.
The reference is okay, but Indian population has vitamin D deficient And there are in other countries also. This is the reference used.
What is recommended for vitamin D as per your
Recommended.
dose for vitamin D correction?
See, it depends on the supplemental or you think of treatment.
Like accidentally the routine checkup vitamin D comes around 12 or 10.
Yeah, 60,000 units per week for it.
Then
Maintain this dose, that is according to age. If your age is more than 70 years, we can go for 800 international units. If age is less than 70 years, we can use 400 or 600 international units.
See, the most common problem is that we are prescribing it day in and day out without getting the serum levels done because the cost is very high.
Yeah.
but vitamin D toxicity.
But toxicity is definitely there because
Right. When vitamin D toxicity happens.
Window is very high. And toxicity occurs usually sometimes see the injectable vitamin D is given 6 lakh units. And simultaneously 60,000 international units is prescribed.
But for oral, suppose
For oral, the upper level of normal limit is 4,000 international.
in Baroda, there are neurologists who advise vitamin D daily. They correlated vitamin D deficiency. Yes. When I
One is the Strauss regimen. One is the Strauss regimen. If you find the patient is not compliant, okay.
यदि suppose अपने daily vitamin D ले, daily बोलती है 6 महीने में वो लेगा ना तो इसको toxicity daily.
Monthly के बाद हो सकता है. Yeah.
Let's therapeutic.
But this is the case I will. If I want to.
therapeutic 100 to 1,000 units per day is enough.
This is the case I have seen.
Apart from the levels, and I don't think patients require more than 3 months. Actually, we should get the levels. Actually, the levels should be reported after 3 months. हम वो देते रहते, that's the problem.
Then we have to go to maintenance dose. After prescribing, we have to shift to the maintenance dose. This is the case. 14-year-old female. Anorexia, vomiting, abdominal pain, calcium level was 11.5, phosphorus was 5.2, PTH was suppressed, and 25 of the vitamin D was 112. And the previous prescription we have reviewed, it was injection, erythritol, 6 lakh unit and state, and followed by 60,000 unit once week for 6 weeks. And this vitamin D level was more than 112. So we have supplements to a stock, dietary calcium restricted and adequate hydration is provided to this patient. But sometimes vitamin D level vitamin D half-life is 2 to 3 weeks and it persists in the fat. So sometimes it doesn't wane away within few days. It can persist for a month or so. Vitamin D dependent hypercalcaemia. In this case, we have to give steroid because steroid inactivate 1-alpha hydroxylase. And it also decreases the intestinal absorption. So, steroid for 2 days we have to prescribe in vitamin D intoxication.
What is your opinion for say TSA in 5 to 10?
So, TSA, first we have to see age of the patient. Age is more than 65. Generally, follow the patient, avoid the patient. Now the recommendation is coming that elderly population should be treated if TSH is more than 10 and anti-TPO antibody positive. If anti-TPO antibody is negative, more than 20. Okay. Because there is risk of atrial fibrillation and osteoporosis. There are two main risks in elderly patients. If patient is less than 65 years of age, we have to go for anti-TPO antibody. If it is positive, then we can start treatment in low dose. Otherwise, we have to see some other factors. If patient is highly obese, BMI is more than 30, okay. In highly obese patient, what happens? Leptin will increase, leptin level, and leptin will stimulate TRH and it will increase TSH slightly. So, general misconception is there that one find TSH is 6 and patient is obese, so they will tell that you are obese because of hypothyroidism. No, TSH is elevated because of obesity in this case. So in this way we have to approach. And we have to see other factors. If patient has suffered from any critical illness in a few months duration, because patient may be in recovery phase, so because of recovery, TSH may be elevated. So in this way we have to.
Patient is 40 years old.
40 years.
No any, say, results from any critical illness or any indoor-based treatment or anything like that. So last 3 months and TSH comes around 9. So
then we have to see any symptoms of are there, easy fertility, pain, any symptoms, and we have to see anti-TPO antibody in this case. Because anti-TPO antibody is positive, chance of developing over hypothyroidism over the 3 months is high. So we have to treat that patient. If anti-TPO antibody is negative, patient is symptomatic, we can give trial of low dose thyroxine if patient responds or not.
How are the phosphate levels related to hypercalcemia? That
See, phosphate level can help in differentiating both. PTH is phosphate unique. Okay. Because of hyperparathyroidism, PTH level is increased and it will increase the phosphate excretion. So phosphate level in primary hyperparathyroidism will be low. But in other cases like vitamin D intoxication, vitamin D also reabsorbs the phosphate. So in vitamin D intoxication, phosphate level is high. So in this way we can help in differentiating the etiology of hypertension.
sorry to interrupt. Dinner is ready, so so gradually. Meanwhile, question answer session is चालू question. So they can ask. So I request few of our members to join the dinner. Dinner is ready. When I need question, you can ask. I know it diabetes, hypertension, all in the brain basket.
But during COVID time period, there were
Not everywhere. Infection everywhere.
नहीं अभी यहाँ पे चल रहा है
But I have seen the cases that injectables is prescribed directly just because of pain without any investigation.
Is there any indication for injectable?
When there is rickets or osteomalacia, we can use a stress therapy, but one injection, then we can do follow-up. These are the indications.
you give dose and OD dose also and the daily dose also for a period of
After this injection, if we give injection, then we go directly come to maintenance phase.
That is 1,000 units per day.
And in this case, we think that compliance will be poor in vitamin D deficiency. In that case, we prescribe this. Otherwise, there are very less indications of. One indication is when there is malabsorption. Vitamin D is not absorbed. Then we have to prescribe injectable.
Symptomatically, this intoxication, when can it be predicted over a period of how many months you have practiced here?
टीचर कल से सीखने वाले के लिए
Intoxication after 15 days of use. So it's a variable time. Mostly it occurs after months.
देखे ना पेट वाले ही सारे खड़े हुए
One patient diabetes, the other one diabetes, the friends are there. एक patient I come to study. FBS was 128. HbA1c was 6.3. What will be your approach?
First time FPS is 128.
128. HbA1c was 129. HbA1c 6.3. So by definition, FBS is more than
One
128.
value or two values? I will repeat the value of FPS.
One value.
I will repeat the value.
Okay.
2 times FPS value is used in the diagnosis. I will repeat the value. If it is again high, then I will assume that.
Comes again high. What will be your first drug of choice?
Metformin. Our lifestyle, we can, if patient is ready for lifestyle, so we can prescribe him diet and exercise, and we can follow. But if we want to, if we can start metformin, no harm, because HbA1c is also in pre-diabetic range, so we can start metformin.
If it does not get controlled with metformin alone, will you go up to 2 grams or you cannot?
No, I will go up to 2 grams, but if HbA1c is 6.5 to 7.5, we have started using combinations after very much trial, linagliptin and metformin. If HbA1c is more than 6.5, so because it is found that if this combination, if risk of secondary glycemic failure that occurs, it decreases. After very much trial results that comes recently.
SGLT inhibitors are not indicated in
If patients have cardiac condition, even if the cardiac some MI or history cardiac condition is there, then first phase is always metformin, but we can use SGLT2 inhibitor along with it. And in European guidelines, they have mentioned that SGLT2 inhibitor is first phase, but ADN still stuck to the metformin.
Somebody is obese,
Yeah.
then SGLT.
For the first phase, no. First phase, no. Yeah.
Patient is obese.
Yeah. We can, patient can lose weight with lifestyle and exercise.
કેટલાક પેશન્ટ એવા કે લોકો મેટફોર્મિન પર તે લોકોને એસટી અપસેટ ઓર સ્ટેન્ડિસ ઓર
Yeah. If it is,
what should be your approach?
if it is not, does not resolve within a few days, 7 days, then we can switch to the sustained release formulation. If patient doesn't respond to sustained release formulation and gastric upset persists, then we have to stop it.
Many patients with diabetes patient complain that the tablet is complete हमारा what can you say?
That's I have not come with it.
some are near, I have seen that they are not.
Is it a manufacturing defect or it is something else?
It can be. It can be. What
They are not very much interested in increasing the dose. That is our failure. We can after 4 grams of dose circulation. After 500 to 1 gram.
Why is affected?
Yeah, 2.5.
Just measure to increase the dose and then do some other thing.
Patient was trying.
So size is problem.
Toma película y se conecta todo that mentality change in your hand. How much counseling you are doing and how much patient is able to understand the importance of diabetes and lifestyle change.
that is very important because lifestyle changes this HbA1c reduction 1 to 2%. And now there are the studies that with only lifestyle changes diabetes can remission can also occur. If person is losing 50% of weight in your weight, then diabetes remission can also occur. Of course, if because back to previous lifestyle, it may relapse, but remission can occur with lifestyle changes. Inhibition can refer to insulin. Because if patient is lean, he usually it will come down. It will come down. With 8 milligram glycerin, it can come down. But first phase of insulin is because if you will, because what is the summary? How it will act? It will force beta cells to release insulin. In severe stage of hypercalcaemia, there is beta cell glucotoxicity. Beta cell function will be less, and we are giving more stress to beta cells. So we have to give the rest to beta cells. So in future, if we use initially insulin, then in future patient can better control with lesser number of drugs. That's why we have to use insulin.
Therefore, we need sugar weight loss, anorexic effect, patient and if it is insulin sensitization, over period of time diabetes progress બ્લડ
એના એક્સ્ટ્રા પેન્ક્રિયાટિક ઇફેક્ટ્સ વગેરે છે.
આપણા પહેલા દિવસ પહેલા એક દિવસ બે ગોળી ચાલે 3 ડાયાબિટીક એટલે બાકી નોર્મલ ઇન્સ્યુલિન 5 વર્ષ 10 વર્ષ જો તમે મેટફોર્મિન યુઝ કર્યો છે તો પ્રોગ્રેશન સ્લો.
Now the metformin is also found to be useful when it is extra pancreatic usage. It is found to be useful it decreases the risk of cancer also. So there are many benefits of metformin. It's a wonderful drug. Still not metformin. It is debatable topic. In first trimester, usually now many continue to use metformin, but in second trimester we have to switch to insulin. Because first trimester it is said it help to prevent abortion and also but it is highly debatable. There is still no clear-cut guideline regarding this. But we used to use insulin. We use insulin. That is just one of the case only. In 35-year-old female, presenting with more pain, polyuria, constipation. Where serum calcium level was 14.8, phosphorus level 2.4, and PTH was 321. It is PTH dependent hypercalcemia. Now we have to find out where is the problem. It is usually primary hyperparathyroidism, and now we have to localize the parathyroid. So we can conduct we have conducted ultrasound in this case, and ultrasound is found parathyroid adenoma or inferior force. And dependent choice in this question is surgery. Parathyroidectomy should be done. Parathyroid adenoma should be resected. And there was a skeletal lesion, skull lesion in this patient. Salt and pepper appearance you can see because of increased resorption. There is salt and pepper appearance. And you can see the X-ray. You can see the resorption, increased resorption in this phalanges. And but this you can see the cyst, bone cyst, small cyst. This all resolved after the surgery, within 1 year of surgery. So there are a few indications for surgery. There are primary hyperparathyroidism. That is patient present with over clinical manifestation. Serum calcium is more than 1 milligram above the upper limit. So these are the variety of indications for surgery. But we can conduct medical monitoring if there is asymptomatic mild hypercalcemia. Now the case number 3 I have already discussed. And case number 2. This is also P3 dependent hypercalcemia. You can see 14-year-old boy, 2 attacks of acute pancreatitis. Calcium level was 11.8. Phosphorus was 3. And PTH was 38. Mildly elevated. We consider it normal, 10 to 65, but we consider it as PTH dependent hypercalcemia. In this case, we have to differentiate PTH with primary hyperparathyroidism from familial hypocalcemia. So, we have conducted urinary calcium creatinine ratio it was 0.009, and other serum calcium was also 11.2. So, we have not done genetic analysis in this patient, but we have proved by this that this familial hypercalcemia, and we are advising medical management. And medical management, we have prescribed calcium. What is calcium? It is calcium sensing receptor analog. It will inactivate calcium sensing receptor. So calcium is not more absorbed from kidney. Repeat serum calcium after 1 month of therapy was 10.2. Why I am discussing this case? Because in familial hypocalcemia, surgery is contraindicated. In familial hypocalcemia, there is also parathyroid hyperplasia. But we can't undergo surgery because there is always recurrence. Because renal defect is always there. So calcium level will not improve after surgery. But if so, it is very important to differentiate between both. And last one case I want to discuss. Then 13-year-old boy, weight 34 kg, presented in the emergency with drowsiness and dehydration, and average calcium was 2.5, and total calcium was 6.6. It was diabetic patient. So it was in hypercalcemic crisis. In this case, we have start treatment immediately. We have your ibuprofen and then we have also repeated. We have also repeated. The ticket was 8.9. It is suppressed. So, severe hypercalcemic crisis with PTS suppressed. But it is
नहीं चलेगा, मैंने हाथ में
hypercalcemia
chair पे।
and in reviewing the history, patient has also
क्या
history of
करूँ
bone pain. So we have conducted skeletal survey. There was multiple lighting lesion. See, multiple lighting lesion in the skull and the humerus. So, state the diagnosis was some malignancy was there. In peripheral blood smears, total count was 24,000. So, total operation conducted by pediatric department, in which they found blast was 39% and diagnosis of this patient was acute myeloid leukemia. We have treated with IV fluid and bisphosphonate injection jolly acid. So I want to discuss the brief about treatment of severe hypercalcemia.
This bisphosphonates, this I am asking one question.
कहाँ पहुँचा
Many patients we see who have osteoporosis on X-ray or are on steroid or on So, can we go on directly bisphosphonate without Dexazone?
Corresponding Dexazone,
Without
if there is vertical fracture,
कवर
rigidity vertical fracture without falling from his height, with minimal trauma, then we can start.
Dexazone, like
Vertical fracture is no.
steroid for long.
Rigidity fracture is there we can start. Rigidity minimal trauma. Yeah, minimal trauma is that we can start.
कल से मैं नेक्स्ट टाइम से स्टैंड लेकर आऊँगी
Zoledronic acid, which is most compliant because it is given yearly, 5 milligram IV yearly. If patient doesn't have renal dysfunction, if GFR should be more than 30.
Renal stone of hypercalcemia. So every patient with renal stones should be investigated.
Yes, 5% of patients with nephronephrosis can have primary hypercalcemia. For every patient of renal stone,
The multiple stone is
any renal stone is there. Calcium renal stone is very cheap investigation. But we have many euros.
Yeah, it is.
Euros.
These are also is.
Yeah.
Suppose one person has FPS of 120 with strong evidence with diabetes. Can we go on for metformin?
Strong family
Then for the father is 40 years.
40 years.
126.
Any history, any what about family history? Then party it is pre-diabetic, we can start metformin. Yeah. Pre-diabetic lifestyle plus exercise or metformin give equivalent result to prevent that. Yeah, obviously, very obviously.
Any weak patient of diabetes, you will advise for pediatric surgery. At least BMI.
Which BMI? See, for Asian population, obesity is considered if there is BMI is more than 27. But still being advised if BMI is more than 30 and diabetes is there, because there is chance of revision if patient is ready to go for surgery, we can advise.
More than 30 BMI of diabetes.
We can
We can advise.
advise.
बस
You can, what is the importance? Isn't it more importance to post-prandial hypertension rather than fasting? Yes.
So both are equally important. Now the guidelines say if fasting plus food HbA1c is normal, then no need to go for post-prandial blood glucose. If HbA1c is slightly high and fasting is normal, then go for post-prandial blood glucose. You see, most of the post-prandial blood glucose is related to higher risk of cardiovascular disease, change life. So we can monitor the fasting in HbA1c. But we conduct both because this is not working. Patients have also indicated to this. Technically, we do all this. And for diagnosis, I will say we have to do more post-glucose test. Not postprandial blood glucose. Many patients come with heavy meal and no postprandial, come with postprandial blood glucose test. But for diagnosis, we have to do more post-glucose test. This is gold standard.
मेरा हाथ दुख गया.
Preservative and patient should have minimum 150 grams of carbohydrate for 3 days.
Somebody says 300.
Practically, but suppose some patients have 200 grams, 201. Then it can be because of heavy meal. Yes.
Many patients are very high also. Basal, 50, regular also was. But you very advanced.
First, I will see the insulin injection technique is proper. Is there any lipodystrophy is there? What are the signs of severe insulin resistance? I will try to prescribe this metformin, paracetamol with insulin also, because it can also reduce the insulin dose. So, but
Well, to be compatible with diabetes.
yeah. In old age, I will avoid because it is the risk of osteoporosis. In retinopathy, I will avoid because it increases the risk of macular edema. Diabetes function, yeah. Heart failure, it also increases the risk of heart failure.
Someone is on diabetes or development diabetes. So we stop diabetes or diabetes.
I think we should stop.
But as soon as we stop diabetes, we need to see level patient being sick.
Well, we can go for metformin, we can think of other drugs, then we have to go for insulin.
बोलो ना.
Then insulin is metformin. And GLP-1 is allowed. That is difficult, but some patients get through. And low carbohydrate diet, we have to advise them restrict carbohydrate as much as possible. Practically simple carbohydrate.
What is the like calcium supplements protein pediatrician भी आता है वैसे तो where is the alarming where we should not give calcium supplements?
Calcium supplements routinely pediatrician have to give for that because
Growing age होती है.
is also common.
Yeah,
See, in this case, more than 4 grams of calcium can cause milk calcium syndrome. That is hypercalcemia. This is again one cause of hypercalcemia. But we have to restrict the calcium around its age is higher, older age, 1 gram. For maintenance, we are giving. Therapeutic that is different. Therapy is different. Suppose the hypotherapy is a patient who is hypocalcemia, we have to give 2 to 2.5 grams. Therapy is different. For as supplement, we should not go more than 1 gram.
the investigation can go, it can give a gram.
That